Everyone, my name is Başak Ceyda Meço. I'm from Ankara, Turkey. Today we will be talking together with postoperative delirium and cognitive dysfunctions. Then later on we can discuss with your questions. But before that, I just want to show you a friend of mine. This is Bella. Bella is 2 years old and she has 5 legs. As you can see, she also has 3 eyes. And these eyes are quite important. When there's a problem, she's quite good with this. Also, she speaks perfect Chinese. Although I don't understand Chinese, when she speaks, I do understand everything. She is such a good friend. Okay, let's stop here. If I continue talking with you with such a fluctuating logic and such a disturbed perception, you will all think that I have something delirious, or at least I have some cognitive problems. But believe me, this is not always that much obvious in all our patients. So we need to focus on these cognitive problems to find them, to see them. So today we will be talking about cognition, and also we will try to define the perioperative neurocognitive disorders, which is a big umbrella of definition, and maybe the most important would be the postoperative delirium. Of course, how to deal with that, we need to talk about the guidelines and how to use these guidelines, who will use these guidelines, and how are we going to implement them is, of course, crucial for us. So what is cognition? If we have to define cognition, we would say that this is a mental process. Cognition is thinking, understanding, learning, and remembering. I just used the ChatGPT, which is very, very popular in these times, and try to find out what cognition means there. So cognition was defined as acquiring, processing, storing, or using an information. It also includes perception, attention, memory, language, problem solving, decision making, and reasoning. So as you can see, cognition is a big definition which needs some attention. If we look to cognition now, how does it change? We know that the major change in cognitions appears with aging. So if we look to the aging process in our brain from the cellular way, we know that there are some synaptic plasticity changes, reduce in synaptic density, the morphology of synapses of neurons changes. Also, there is a huge inflammatory process. The inflammatory cells start secreting some different inflammatory cytokines, and they are not cleaning the environment as they do when we are young. Also, there is a huge degeneration, and the regeneration is not here anymore, as we know, the neurogenesis. And in the blood-brain barrier, we also have some problems with the vasculature change. So the main topic of cognitive dysfunctions that we see during aging is based on inflammation. What happens during surgery? We know that the surgical procedure is a huge inflammatory process. So Rasmussen defined perioperative neurocognitive disorders as brain function affected during the immediate period after surgery, after anesthesia, with a depressed level of consciousness and an impaired attention, memory, reaction time often being reported. So these are the cognition definitions. And there is no simple answer to the question, when brain function is back to normal after anesthesia. Also, he says that if all the difficulties were due to the anesthetics, one would expect the cognitive functions to have recovered to a preoperative level of functioning when any drugs affecting cognition have been cleared. Actually, these 3 statements are quite important, because when we talk about immediate, is it really immediate? What is the timing? What is the time frame of cognitive problems? It is important to define. And again here, when we say that when brain function comes to back, do they really come to back, all the functions, or are we losing some of them during this perioperative period? It is also important to assess. And talking about anesthesia, is it only anesthesia, or do we have also surgical impact on these cognitive disorders? Of course, yes, because inflammation is a big package coming from anesthesia, from surgery, from healing, from everything. So the pathophysiological definition of perioperative neurocognitive disorders would be a breakdown in brain function in individuals due to impairment in brain connectivity and brain plasticity with this surgical stressor. What about the etiology? There are several etiological factors that can be defined, as the patient may come to the operating room or to the hospital with some undiagnosed neurodegenerative diseases that appear with these perioperative processes. They may also have some other comorbid systematic diseases that influence cognitive functions, but the main topic, the main etiology is always defined as inflammation, which is resulting of a neuroinflammation and gives us some neurological damages, and they are all due to surgery, stress, anesthesia, but also healing. So Everett and friends just try to define this time frame to us with increasing the way of looking. So now, as we are perioperative doctors, we have to look to our patients preoperatively, but also postoperatively. So they just wanted to define different time frames to have the same language when we are talking. So we now know that some patients may come to the hospital with already preoperative cognitive impairment, neurocognitive disorders that may be known or unknown. Also, all these patients may experience some perioperative problems. If these are early problems, we mostly see the postoperative delirium, and we see postoperative delirium till discharge. But also, we can see the delayed neurocognitive recovery, which is seen for 30 days after surgery. And Everett highly recommend us to follow up our patients even longer. And for 1 year, if the patient has a cognitive problem, we still name it as a postoperative neurocognitive disorders. But after the first year, it is not related to this surgical period anymore. It is important to know these different nomenclatures and to use them correctly. Because when we have a perioperative problem, we should be aware that we are faced to this frail brain that we have to care, we have to be careful. Also, we need to monitorize these patients in the perioperative period. And when I'm talking about monitoring, it's not only the routine monitoring, but taking care of our patients, knowing these problems and following up our patients related to these clinical situations. But also, we need to follow up these patients even after the hospital stay long enough to assess and to recognize all potential postoperative neurocognitive problems. So if we have to focus now on this delirium, which is also this postoperative delirium, which also leads to long-term problems. So if we focus on delirium, we should define delirium by the definition of DSM-5 criteria as disturbance in attention and awareness. What does it mean, problems in attention? It means that there is a decreased ability to focus, to sustain, but also to shift the attention. And when we are talking about awareness problems, we should be aware of a decreased orientation to the environment. These problems may develop over a short period of time, but also it's important to know that these are changes from the baseline. What was the patient before this perioperative period? What is the patient now? But also it's very important to know that these clinics fluctuate. So you may see a patient quite normal, and then the patient may go through a postoperative delirium and became again normal. So it's important to assess your patients on a good time frame and repetitively. And of course, there is a disturbance in cognition, which means memory deficit, disorientation, language problem, visual problems, and also perception. So this is all related to the definition of cognition and what we lose from this cognition. One important topic is that this postoperative delirium is defined in 2, even 3 different subtypes, phenotypes. And unfortunately, most of our patients experience hypoactive delirium. What does it mean? It means that only 20% of our patient has a hyperactive delirium. They are excited, they move, they are not happy. They really show you that there is something wrong. But the majority are just sleeping, not answering, not communicating. And for some of our young colleagues, these are good patients. They are in the PACU and we don't need to do anything to them. But this is very frightening, because if you miss this diagnosis, then as I said previously, you will experience all the long-term problems that are related to postoperative delirium. And some patients have sometimes hyperactive, sometimes hypoactive. As we said, that it's fluctuating. It may change also from type to type. and it may still be different to diagnose. So we should be aware of POD as hyperactive, but also and mostly hypoactive clinical scenario. Why is POD so important? Because the incidence of POD is quite high, especially in some surgical specialties as cardiac surgery, orthopedic surgery. We may have as high as 65% of patients having delirium. Also, our elderly patients are in high risk for delirium. For more than 50 years now, people are working on these POD incidences and clinical scenarios, and it is becoming a more and more important problem for all of us. Why POD is important? As I said, it is the most important complication after surgery, especially for our elderly patients, but also early POD may increase the postoperative care unit stay, length of hospital stay, but also the non-delirium complications within the 30 days, which is a long period of time and a big spectrum of complications. It also increases the hospital stay and logically the cost of the procedure, but it also increases the risk of readmission. So it's a big problem that doesn't end once it's here. But also patients experiencing POD may have some decline in their functional capacities and became dependent during their daily living. So these patients may be very well and living alone preoperatively and become dependent to their caregivers during the postoperative period, which is a huge problem. So as I stated before, there are several publications showing us that if we have this POD in the early postoperative period in the PACU, in the area that we see our patients, that we monitor our patients, that we can catch this problem, we may have even worse problems in the postoperative long term. A patient who has POD in the PACU are high risk for having POD on ward, but even some publications, not many, but some publications states that postoperative delirium may lead to PONV, mortality, high pain ratio, as I previously stated, high cost, high length of hospital stay. So it's an important definition, it's an important clinic that we have to catch, it's an important problem that we need to prevent. Are we going to leave this problem going through? Of course not. We need to manage these patients. As I said, we need to assess our patients, especially high-risk patients. So how does guidelines save lives? Of course, guidelines save lives if we use them correctly. So European Society of Anesthesiology just defined us what to do for postoperative delirium in 2017, and the new guideline is coming. We know that from the European Society webpage that we will have an update in a way to this guideline. What does the guideline say us? The guideline says us that there are risk factors that we should be aware and we should assess in our patients, and also it gives us some clue about monitoring those patients to detect delirium, but also to detect high-risk potential patients. And also, the guideline defines us how to prevent delirium, but also how to treat if needed. So what are the risk factors? We have to define these risk factors in two different topics. Some of them are predisposing factors that we can't always change, but we also have the precipitating factors that we can influence. When we look to the predisposing factors, of course, age is a problem, comorbidities are a problem, alcohol-related disorders, and comorbidity scores, malnutrition. Of course, the baseline cognitive status of the patient is important, but also the sensory impairment and the surgical site, the surgical duration, and the functional status, the frailty of the patient is important risk factors for postoperative delirium. What we can prevent is the duration of surgery, the pain, which is a huge precipitating factor for postoperative delirium. Also, bleeding and fluid fasting times are quite important, and maybe bleeding is not as preventable as we might think, but fluid fasting time is an important parameter that we can control. Electrolyte imbalances and drugs that the patients are using are also defined as precipitating factors. In 2023, Hogma and friends also just defined some other precipitating and predisposing factors in their review published in EJIC. We here have some additive predisposing factors as anemia, which is also in some points preventable. Also depression, polypharmacy, low level of education. These are newly defined predisposing factors. And for precipitating factors, we have the sleep-wake disturbance, use of catheters, physical restraints. These are all things that we can change in our patients' perioperative periods. So, what should we do? We should monitorize our patients. As I'm talking from the beginning, it's very important to follow up, to assess our patients, even in the preoperative period, but also in the early postoperative period, to catch even the hypoactive delirium patients. So all patients should be monitored starting from the recovery room. The recovery room is an area that we are very aware of our patients, but at the same time, sometimes we forget these patients because the surgical problem is resolved, anesthesia is given, and we are just expecting our patients to awake in a better way to be sent in the ward. So it might be sometimes difficult to catch these patients there. So we need to have an algorithmic approach, a repetitive approach, and all patients starting from the recovery room should be monitored according to POD appearance, and they should be also followed up for at least postoperative 5 days. It is even more important for high-risk patients. We really need to monitor our high-risk patients during the postoperative 5 days, at least till the discharge, to catch this potential fluctuating clinical scenario and to treat it as soon as possible. Also, this monitoring tool should be validated and should be easy to use for all users. So what are the different monitoring tools? You have the 480, you have the CAM, you have the NuDesk. The important thing, I would say, that you should be using the method that you are used to use. I mean, it should be your routine. It should be like your daily routine that you do. If it's something new, it will be difficult for you to use. So you have to choose a test for yourself, for your clinic, for your patients, and you have to use it repetitively. It is the advantage of using the same test every time is that it's easier. It aids you to identify POD patients, even with the hypoactive ones, as I'm stating for several times now. But of course, it's difficult because you have to train your personnel and you have to reinforce your team to use it. It has to be sustainable, which is not always quite easy. So the test that you are using should be sensitive to changes. You have to catch the changes during the time frame, but it should be easy to do, not only for your team, but also for the patients, because the patient is recovering, trying to wake up, so it has to be short. If you have a very big tool, then it will be very difficult for your patient to answer, to cooperate with you, and it won't be easy then to catch the POD definition. Of course, this test needs to be validated to your language, to your culture. Otherwise, it won't give you correct results. And the timing and the repetitivity of the test is important, because when we talk about postoperative delirium, we always say that it has to be repeated because the clinical scenario is fluctuating. So you may have delirium in PACU and the patient may recover, but the delirious clinical scenario may be repeated during the ward stay. So it's important to repeat this test. And we also recommend to repeat the test during the same time frames every day, early in the morning or in the afternoon, the time frame that delirium is high. So what should we do to prevent or treat delirium? There are several recommendations to prevent delirium, as implementing fast-track surgery. We know this now with all these ERAS protocols that we want to discharge our patients as soon as possible from the surgical scenario, not only from hospital, but from the surgical trauma, inflammation. Also, of course, the use of benzodiazepines are not recommended. It is highly recommended not to use it if it's really not necessary. Of course, we have some patients that really need these sedations. They are so anxious that benzodiazepines may help. It's not a no for sure, but we have to be aware that benzodiazepines are not good for potentially high-risk patients for delirium. Also, pain is an important parameter, but also depth of anesthesia is quite important, because depth of anesthesia and pain are really parameters that we can interfere and we can change our patients' recovery. We know now that with pain, we need to have a continuous intraoperative pain management for a better outcome, but also depth of anesthesia. There are many publications about monitoring depth of anesthesia, and we know that monitoring depth of anesthesia decreases postoperative delirium or postoperative cognitive dysfunctions. There are different publications related to that, but I just wanted to show you these publications from Bratke and friends, which is not quite new, but which is important because it says that there are some independent predictors of POD and this value below 20, because we used to follow up the depth of anesthesia in some margins, some limits, lower limits, higher limits. So if you have a lower than 20 BIS value, the percentage of this value may increase delirium. Also, the suppression ratio, which is the time of depth of anesthesia monitoring, that says that the EEG monitoring is almost isoelectric. You have very low electrical activity. So these are predictors of POD. This is a very important data to assess, but also POD may be an independent predictors for mortality at 3 months. These are discussable. The mortality results are discussable, but then the depth of anesthesia monitoring is really crucial, and you should be really aware now of that there is another method of monitoring, not only the numbers, but we are also trying to monitorize the wave distribution, and these photos, these graphics are more and more coming in our EDAIC exams, because these are important monitoring tools that help us with our patients' outcome. So what we want a nice alpha delta dominant DSA photos, as you can see in the photo, which is in the right up corner. This is a very teaching publication of Purdon and friends, published in Anesthesiology in 2015, which gives you several examples of DSA monitoring, which explains you the philosophy under this monitoring. And what we don't want the burst suppressions, too deep anesthesia, too much of anesthesia. Here you can see that there were repetitive propofol boluses that gives us burst suppression. In many publications, it is stated that burst suppressions gives us postoperative cognitive problems. So these parameters are important parameters to follow up. Also, in prevention, I want to emphasize the importance of non-pharmacological measures, because when we have a problem, we always want a recipe to that, to give a medication and to cure the problem. But prevention, because giving a medication and curing something is quite fancy. But if you prevent something with non-pharmacological methods, it may seem very basic. But then, on the other hand, it's not costly and it's very easy. And the guideline recommend us to implement some non-pharmacological measures to decrease POD. These are very easy measures. Orientation, which means that you can tell your patient what time is it when they wake up. Visual hearing aids, you can give your patients their eyeglasses, you can give their hearing aids, or you can just tell them it's morning, it's nighttime. You can just take off all the catheters that are not needed, and you can, of course, early mobilization, early nutrition. These are very easy to do methods, and they help for postoperative delirium occurrence. So in 2021, Burton and friends just published this Cochrane analysis about the non-pharmacological interventions, and they just assessed several studies and more than 5,000 patients, and they found that measures as the orientation, cognitive stimulation, sleep hygiene, attention to nutrition, hydration, oxygenation, all these mobilization, pain assessment, pain management, all these non-pharmacological and non-invasive, in a way, methods were able to decrease POD incidences by 43%, which is a very big number. These studies, different studies also stated that length of hospital stay decreased, delirium time decreased. They had some minor results, minor positive results, but the most important one is that all these non-pharmacological, non-invasive methods decreased postoperative delirium incidences by almost half. So this is, I think, a quite important data, recent data from Burton and friends. So how should we preserve? We are talking about all kinds of preventions, non-pharmacological preventions, and then who will preserve? I can give the answer to this question as all of us need to be active. All the medical staff, anesthesiologists, nurses, surgeons, patients, relatives, we all need to be active in this process to preserve the cognitive functions of our patient. As an example, the Safe Brain Initiative is an important initiative, is an important non-invasive approach to preserve cognitive functions of all surgical patients, knowing that all these postoperative problems as pain, postoperative nausea, vomiting, stress, agitation, sedation, and POD are related to each other, because when you give medication to kill pain, you may confuse your patient, or when you give too much of painkillers, you may give your patient some nausea and vomiting. So they are all mixed together, and what we aim is to be on the right, on the middle, on the blue spot of this flower, and for that Safe Brain Initiative proposes you to use 13 different non-invasive recommendations as managing the fluid fasting of your patient, try to educate your staff, your patient not to be dehydrated for hours and hours, or as we stated previously, to monitor the depth of anesthesia and try to stay in the safe zone with anesthesia depth. But if we have to summarize all we are saying with this nice review written by Hogma and friends in EJAIC 2023, I can say that it's very important to identify high-risk patients and to optimize these patients' preoperative status. So tests are important to define, but then the optimization can be done with several non-pharmacological interventions as cognitive stimulation, decreasing the fluid fasting time, or treating even the preoperative pain. Also, during the intraoperative period, as we are the perioperative doctors, it's quite important to take care of this homeostasis and to minimize this stress, this inflammation, which now we know will give us many, many complications, and POD as one of them. But also, it's quite important to give our patients a good postoperative period with good analgesia, good monitoring, and good orientation, giving their eyeglasses, giving them water to drink, and of course decreasing any kind of catheterization, and trying to send this patient as soon as possible to their routine, regular, real life. So cognitive functions are quite important. If we have to sum all that we have said, I can tell you that cognitive functions are quite important. It's a very big and very detailed function that we need to preserve for a better postoperative period. For that, we need to assess all our patients related to their baseline cognitive status, to find out the high-risk patients and to preserve their cognitive functions. For that, we need to use these guidelines that gives us lights. It's important to implement, to use them on a regular basis. It's important to have a sustainability about this guideline usage. And I think that precision anesthesia care is quite important in these days for a better outcome in our very specific patients. To improve the outcomes, we need to have an individual patient-centered care to change the real world data, to change the real clinical scenarios, and for that it's quite important to assess the overall postoperative, perioperative period with pain, with sore throat, with delirium, with thirst, with any kind of outcomes, patient-related outcomes, and to focus, to put our patient and our patient-related outcomes and delirium also on our focus to have a better postoperative period with our patients. I want to thank you all with this nice gravure from Turkey, Istanbul. Thank you for your attention. So, which of the following statements are true related to postoperative delirium? A. POD may increase the risk of readmission. B. POD is a rare postoperative complication primarily seen in young people. C. Non-pharmacological intervention can reduce POD incidence. D. POD has a fluctuating clinical presentation during a day. E. Fluid fasting time is a precipitating factor for POD.